afternoon, morning, whatever it is when you're watching this. Welcome to another one of the Aesthetic Society Roundtables. We're here today to discuss breast implant illness for the clinician for all of us. I want to introduce you my other panelists today, Dr. Pat McGuire from St. Louis and Dr. Lou Strock from Fort Worth, Texas. I think we all have some similar, some different experiences with BII, and we want to share with you today what has worked in our practices, things to watch for, and how to talk about those urban legends that the patients come in with. Hey guys, how are you?
Good.
We're great, thank you.
Good, excellent. I personally see a few breast implant illness patients. I do several a month probably, but it's not the majority of my practice, and I've worked hard to communicate. Some of them are my patients, some are other patients. If you could both just kind of share what your experience is.
I see quite a few breast implant illness patients. I probably do 3 or 4 a week. I still do implant surgery. I tell these patients that I do not believe implants are in and of themselves poisonous. They have a right to have their implants removed. And they're actually very nice patients. They've been through a lot. Usually by the time they get to you, they don't feel well and they can't figure out why. So it's a process of making sure they've had appropriate workups before they get to you, and then talking about the risks, benefits, and whether or not I think they'll get better or not get better with removal of their implants.
BII patients don't make up a large part of my practice, but I do a lot of revision implant surgery, and I really try to talk about the social media groups, the BII issues, to try and establish the importance of communication and the importance of follow-up. So I try to treat all my patients as though they might have questions related to BII, and I'm trying to prepare our communication to be able to handle that if it goes there in the future.
It's amazing how many new breast augmentation patients I will see that know about it.
Yeah.
They've been on the sites, they've looked into it. It's good because no one can say nobody told me about this, and it's part of my implant consultation now. I discuss it specifically. I tell them about the groups and tell them they may want to consider this so they have the entire picture, because you hear from so many of the BII patients regret.
Yeah, and that they didn't know. And I think that is very important. When all of us see these patients, I think the patients come to us with varying levels of workup. And certainly I have used the Aesthetic Society pre-explant questionnaire because it's helped me at least be able to get a handle on what complaints do they have, and then we can use the follow-up questionnaires to see which ones actually go away, which ones don't. But the workup they have when they come to me is highly variable. Are there certain lab tests that you feel like the patient has got to have before you have surgery? And, I'm conflicted because we need to be good doctors. And if there's another reason for them feeling bad, we've got to help find that. Yet I don't get a big extensive lab workup for patients who want their breast implants out just because they've gained weight or they're postmenopausal. So Pat, what do you do with the BII patient?
But first, I get the records from, because a lot of them come in and say, I've had a very extensive workup by their functional medicine doctor. Some of it's been by their gynecologist. And I want to see what exactly they've had done. I do think it's important to check thyroid function, because a lot of the symptoms they have are similar to patients with hypothyroidism. Hormone levels, because perimenopausal women will have many of the same symptoms these patients have. And lab work. I had a patient, breast reconstruction patient I actually saw yesterday, who said she was starting to feel bad. She thought it might be from her implants. And then she had some lab work done. Her calcium was elevated, and she had hyperparathyroidism. So I like to see what they've had done. They haven't really had any lab tests done. I recommend they have thyroid function. Vitamin D levels. I've seen a lot of these patients are vitamin D deficient, which also has similar symptoms. And then thyroid function, and make sure that their mammograms are up to date, and regular physicals with their doctors as well.
What I would add to that also is that I really like to approach these patients from a multidisciplinary angle. In other words, I like to have a good primary care doctor involved and a rheumatologist involved, just in my community, the way it's set up for me. And then my goal is to be in the conversation, everybody to be communicating, but try to make sure they have really good medical care and the patient understands that we're establishing a rapport to make some difficult decisions without clear answers.
And I think that's the important thing, right? We are still doctors, and I think sometimes our patients forget that we're not just technicians, we're doctors, and it's important to take care of the whole patient and to have that good team. Personally, I had a patient come in who was a year out from her implants and was sure that's why she was feeling bad and spiking temperatures, and ended up the temperatures were from a cancer. So, and we got her worked up before we just jumped into doing implants. So I think it's important to still be a doctor and still look at these patients as a whole, and know that there are certain things, thyroid, hormones, that do affect these, and patients need to be aware of that. And then, you know, the bottom line is patients choose to have implants in, they can choose to have them come out at any point in time, and we're all there to help them do it. What are other things that we have in the discussion when the patients come in? I think we've all heard about the on-block capsulectomy versus total capsulectomy versus no capsulectomy. Talk to me about how you guys have that conversation with patients.
I would say that part of the discussion in getting to know these patients needs to focus on what the sources of information are for the patient, and to learn about them, and try to see if we can walk across the bridge, if needed, to a more scientific-based planning. And so carefully conveying that we're all trying to figure this out, but we need to base it on information that seems to be from a reliable source, as opposed to many on these issues that are not reliable. So to me, I think that's another really important part of the conversation, to move it where I can get comfortable in taking care of them. And I have some frame of reference on what their baseline view of this is coming from. To me, that's a very important issue.
Yeah, most of these patients come in with a checklist of questions they're going to ask you, and what things it almost demands of what they want. You know, they would like the implant removed with the capsule in place. They use the term on block, which I'm really trying to steer them, and we've been working with some of the patient advocates to steer them away from that term, which is a cancer term. You know, this is, we're not removing tissue around it. We're not trying to get margins. But the patients believe that whatever bad humors are in the implant, and I asked a group of the patients, what do they think is the cause of their symptoms? And the number one was heavy metals coming out of the implant into the capsule. So they believe that the only way to eliminate all of their symptoms is to get rid of all of these toxins. And that's where Lou said science has to come into it. And we have an ASERF study that, Mindy, you're one of our investigators. We're actually trying to put some science behind this. We're doing a prospective blinded tissue study. We're taking capsules on these women and capsules on women who don't have symptoms, and we're sending it blinded to be tested to see, are there heavy metals in the capsule? Is there bacteria or fungal DNA in the capsule? And hopefully we'll have that wrapped up in the next couple of months, and we can actually give these women science rather than social media data on which to make these their decisions. Now, whether the capsulectomy is very important to them, I believe it's part of the psychological treatment, so that if I can safely remove their implant and the capsule together, I do that. I do not guarantee to the patients that I will do that. Will not tell them that, you know, for sure. I'm not going. I always tell them I'm not going to collapse your lung in order to get some little piece of the intercostal space of a thin capsule and a saline implant. But if I can remove the entire capsule, for a lot of these patients, that's psychological relief, because they truly believe that they have to get every little piece of capsule. And that's this retained capsule is the next phenomenon coming up, where these patients don't think the capsule's removed and they're going back to have more done. So the capsule is an important topic. They need to understand the risk and benefit, whether it can or can't be done safely. They always want pictures of the capsules. They want pictures of the implants. Some of them want to have their implants, and you have to talk to your hospital or surgery center to whether or not they'll let the patients have their devices afterwards as well. So it's a long conversation. It's one they have to understand your reasoning as to why you're doing it and talking about it. And I think we have to be careful, because sometimes these patients come in and just demand an operation, and it would be easy to just take their money and do the surgery. But I think we need to be sure we have the same conversation with these patients, any other patient we have, about risk and benefit.
And along with that study, Pat, I think it's important to note that we are looking at what potential causes could there be. Are patients just reacting to a foreign body? Are they reacting to a biofilm? And hopefully we'll have some answers. And much like removing a splinter, maybe it's removing the implant is enough. But again, not all capsules are the same. And I think this is also part of the education. We know when we see a big, thick, calcified capsule, we want to remove it anyway. It's not even a question. And I think patients need to be educated the difference between a thick, hard, calcified capsule and a tissue paper thin one. And if we can get it out, we will. Or depending on the clinician, maybe you're not comfortable doing that and peeling it off the ribs. But it's a conversation to have with the patient.
Yeah, one other thing I might add to that, I completely agree with what each of you has said, and I think that the other issue to convey to these patients is that there can be some cost in terms of recovery and added inflammation from removing a capsule that otherwise doesn't have to be removed. And it's a very important communication point that ultimately it probably needs to be a game time decision where I like to feel that I'm comfortable, that the patient's comfortable with our agreement on what's going to happen with the capsule, but part of that's determined in the operating room. And if I leave capsule, I try to make a short video of it and give it to them if they want it for some reason, but explain to them that for many revision patients, in the absence of an abnormality, that capsule can be used as a building material that's very important to try to get them to a good place with their revision procedure.
I agree. Pat, you alluded to, we were talking, the retained capsule phenomenon. And that's another part of the conversation, right? That capsules occur all over the body. They occur around pacemakers. They occur in the abdomen when we do a tummy tuck, when there's retained fluid. And I think patients don't necessarily understand that a capsule is not unique to a breast implant. It's your body walling off something that it's trying to protect itself from, or it's trying to separate from the body. This retained capsule phenomenon, I think, is we've got to be careful, as there's unfortunately plastic surgeons out there that say they can remove retained capsule, when we all know if we've taken out an implant, taken out every bit of capsule, if there's even a teaspoon of fluid left, the body makes a new capsule around it. And I don't know, do you have a solution? How do we have that conversation with patients so that they're not going from doctor to doctor, getting different stories, spending more unnecessary money with more unnecessary surgery, more general anesthetics?
I think there's two components to that. One is educating the patients. And I think hopefully when our study comes out and we have some data one way or the other about is there something in the capsules that need to be removed or not. And we have control groups. We have patients, symptomatic and asymptomatic patients. We also have patients who've never had implants for blood work as a control. So we're actually, which most of the studies don't on these patients. But I think the patients need to understand that a capsule is it's scar tissue. It's a normal thing that happens. I had an interesting patient who, by the time she got to me, she'd had 16 operations. And the last two before she came to me, one was an on-block removal of her capsules, but the surgeon failed to take pictures of that. And so she was not convinced that she had an on-block removal. And then her symptoms persisted after her implant removal and capsulectomy. So she went to a functional medicine doctor who told her that the problem was retained capsule. So then she went to another doctor and had this retained capsule removed, and her symptoms still didn't go away. So she was convinced there was something else going on, went to someone else, had another retained capsule procedure, and came to me with just a disaster on her chest. They tried to do a lift with the last time, nipple died on one side, and she decided she just wanted a mastectomy. And she was convinced all the capsule had been removed, and she just says, I'm tired of all this, I don't want anything. So I did mastectomies on her. When I got in there, I found big capsules, seroma cavities with capsules on each side. And I showed her these photographs and I said, you've had 3 operations to have your capsule removed, yet you still have a capsule. And she said, can I have those pictures? I'm going to put them in my social media group for these people to see. She says, how ridiculous it was that I went through all of these operations. I think the other problem is the surgeon's willing to do this. And I have asked several of these physicians to give me their reasoning why they think these patients need the retained capsule removed, and I've not gotten an answer from any of them. And I've asked them, do a paper on this. We need some scientific reasoning as to why this needs to be done, and I have not gotten any data from them.
Patty, you're at the forefront of helping us to figure all this out, which I appreciate, because at the end of the day, as physicians, we need to be careful not to take advantage of the anxiety that these patients have. And it's very difficult for us to have a conversation that sort of ends up at an answer no on doing an operation, but sometimes, and this is a prime example, we have to be really careful to proceed with it.
We've talked about the en bloc capsulectomy. We've talked about the retained capsule phenomenon. What about this? A lot of patients we talk to believe that the minute they wake up in recovery room after having their implants and maybe their capsules removed, they should feel immediately better. And there's a lot of posts on social media, the heal is real, and it's an immediate response. And I talk to patients that if we believe it's the implant and your body has an inflammatory reaction against it, it takes a while to wash the cells out. It shouldn't be immediate. If it's a biofilm phenomenon and it's bacteria, again, it's going to take a while to clear that from your system. So that anything immediate, in my mind, is probably more the lessening of the anxiety. How do you approach, and when do you think the symptoms that go away, we know are going to stay away? Because I think a lot of those immediate relief symptoms come back. So Pat, when do you tell them that they should expect symptoms to go away if they're going to go away? And how do you deal with, I didn't feel better immediately?
I tell the patients that they probably will feel better immediately because most of them do. They've gotten IV fluids, they've gotten some steroids, they've gotten some pain medications. And I have seen patients, the reason I'm doing this research is because I do think there's something to this in some patients. And I have seen some patients that looked very ill prior to their surgery. You see them a month later and they look like different patients. They always say the whites of their eyes are much more white. And I've seen patients get better. Now, is it physiologic? Is it psychological? Is it a combination of both? Maybe. But I tell the patients that I don't know what symptoms are going to get better. The other problem is they come in with so many symptoms. And one of the things we're doing on our study is prospectively looking at the symptoms they have 3 weeks, 6 months, and see what gets better, what doesn't. There's no specific pattern on this. There's 100 different symptoms. I always tell them if it was 4 things that everybody had, it'd be much easier to wrap a bow around it and say this is the cause. And I have a lot of the same symptoms that these women talk about, and I've never had breast implants. So I tell them that I don't know whether their symptoms are going to get better or not. I've seen miraculous women who are very sick get better. I've had a couple people that had Hashimoto's thyroiditis that improved afterwards, and that's a lab data that got better after they had surgery. But I've seen a lot of patients do this, up and down, where they may get immediate relief, then it comes back, and then they may get some. And I tell them maybe not all of your symptoms are related to your implants. So it may be of the 64 symptoms that you came in with, maybe only 40 of them had something to do with your implant. So I can't tell them, since we have not found a pattern, we've not found any configuration of symptoms that do or don't get better. And that's one of the things we're looking at with a control group of women who've never had symptoms, to see if we can see if there's symptoms that will or won't get better. But I tell them there's no guarantee what symptoms will or won't go away, how fast or slow they will. Most studies say if the patients have the previous studies, they have no abnormal labs, and they think they're going to get better, 70% of patients will see improvement in at least some of their symptoms, at least temporarily.
I've dealt with a small number of patients who have been in this situation, like you mentioned, and to me, the biggest challenge that all of us face as plastic surgeons is managing the expectations of our patients. And if it's ever true, this is it. This is the most challenging group of conversations. It's the most challenging management of expectations. And the best I can tell them is I really hope you feel better. If we've got a good reason to go to the OR and we're going to the OR, I hope you feel better. I can't guarantee that. Mm-hmm. We're all rowing in the same direction, and I hope you feel fantastic after. And I've actually seen people, a couple that I'm happy for them. They felt better. Did it have anything to do with the operation? Not particularly. There was nothing abnormal, and we removed implants and did an auto augmentation and got the implants out. And so the psychological part of this is powerful. It's not all of it, but it's powerful until we figure out a little little more specifically the science that you and your group are working on real hard.
So bottom line, we tell patients, we're here to help. We put in implants when you want them, and we'll take them out that you want them out. We need to make sure there's not another medical problem going on. And when we take out the implants, most people feel better in some regards. We can't tell you when that's going to happen, and we can't tell you which symptoms are going to get better, but we're looking at it scientifically. Does that kind of sum it up?
Yeah, what these patients want to hear from us is that we believe they have their symptoms. We don't think, and there's no evidence that this is, they're hypochondriacs. The symptoms they have are very real. We can't directly relate them scientifically to their implants, but I think they want to know that we believe them. And as a society, the Aesthetic Society believes enough that we got the largest grant ever given by the Research Foundation to do this research, because we want to know if there's something going to this or not. So we believe they have symptoms. We want to know whether it's caused by their implants or not. And we're here to help them. You know, we want to do what we can, and the support that we've received from this study from all over the world, I think surgeons, patients, and the patient advocates and all have been very supportive of this. I don't know what we're going to find. We have a lot of data. It's kind of swimming in everything that we have now, but we're going to look through it and see if we can't find, I hope we find something on some of them, but I don't know what we're going to find when it all comes out, because they say it's a blinded study.
Yeah, this is a great opportunity, and I think the society and many are working to make sure this is very collaborative and inclusive of discussions, because patients do just have to understand at the end of the day that we're listening, we're sympathetic to the fact they don't feel well. And sometimes the science does not give us a clear answer, but we're here to help.
We're here to help, and we're working to find the answers through science, but we're still here to help, and we're listening. Well, thanks, guys. This has been exciting. Again, you want to see more of these? There's several different Aesthetic Society roundtables, and thanks to Allergan for the support.